welcome everyone. I'd like to thank you for coming to the Wednesday, May 21st Resnik Grand Rounds. I tell you what, this is getting very, very popular. We have 12 cases tonight to go over, and we unfortunately we didn't get to about 4 or 5, but we'll get them on the next Grand Rounds. Before that, I'd first like to introduce as you know, Dr. Hussein Tarek, who is a prosthodontist with ITX. He's the chief clinical director of ITX, one of the best template and guided companies we have, and we do all of our treatment planning with ITX, and Hussein is very, very good, as you will see. We also have Dr. Rick Robinette, who is always with us, our clinical director at the Resnik Implant Institute, who will be here to answer any questions while I am lecturing. So please, at the bottom there, just put any questions, and Dr. Robinette will get right back with you. As you know, I always do a quick little controversial subject or a topic in implant dentistry. And the one that I picked tonight, first of all, it's going to be very, very quick because we have 12 cases, is going to be what do we do with these hyperdense lesions? And the reason I'm going to talk about that is over the weekend, we had our module 2. I saw 2 cases this past weekend, and we actually have 1 case tonight of a hyperdense lesion right where we're going to place an implant. So I'm going to talk about hyperdense lesions. What is the protocol? What's the later state? And give you basically a take-home message for this. So when we look at hyperdense lesions, these are osteosclerotic areas that are basically in the bone, in the areas where we're going to be placing implants. And there's a whole slew of possibilities of differential diagnosis. If we look at what the literature states on hyperdense lesions, there's no clinical guidelines or no accepted protocols on any of these lesions. We're used to, as you know, throughout the Institute, we talk a lot about osteopenia, osteoporosis patients with low density. Then we also talk about really hard or D1 type of bone, high density osteopetrosis patients. However, tonight what we're going to do is just talk about localized areas of density and placing implants into these sclerotic areas. First of all, if we look at the majority of lesions that are sclerotic in the upper or the lower jaw, the majority of these are active lesions. They're infectious processes, and they need to be removed and or biopsied. So let me just go through a couple of them. First of all, the seminoblastoma, usually at the apex of the posterior mandibular molars. We have the odontomas. They can be the compound, which is usually in the anterior maxilla, or the complex, which is in the mandible, but usually around impacted teeth. We have the osteosarcoma, which is usually in osteoblastoma, in the mandible. It's slow growing. However, it's usually an expansive lesion. So it's very, very large. And usually there is a radiolucent border around that. And then we have semino-osseous dysplasia, which is where the bone actually becomes replaced with fibrous tissue. So you have a mixed type of lesion. With any of these lesions, you do not want to be placing implants in because most of these are infectious or they're expansile lesions, and these are ones that need to be removed and or biopsy. However, if we look at placing implants into osteosclerotic lesions, there are some lesions that the literature has shown that we can successfully place them into. So if you look at the lesion here on the left, this osteosclerotic lesion, placing an implant through it, we just have to modify our surgery protocol. Now, if you look at the most common, and the most common is the idiopathic osteosclerosis. This is usually at the apical end of teeth, and this is an area of just sclerotic bone. That is probably the most common we're going to see. Also, You can see here, here's one on the maxilla on the left, and here's one on the mandible on the right. Also, condensing osteitis. Condensing osteitis is usually around the mandibular posterior molars. This isn't a sclerotic lesion. Now, it's usually associated with a tooth, it's a sequela from a post-op infection or a periapical radiolucency. However, if you take out the tooth, you're going to have this sclerotic bone that is basically a residual sclerotic scar. So if we look at these two type of lesions, I say you can actually place implants through. What are our challenges? First of all, this bone has almost no blood supply because it's all basically cortical bone. So without the blood supply, that area is going to heal a lot slower. Secondly, when we drill through it, it's going to generate a lot more heat. So when we do perform surgery and perform our osteotomy, we want to use a lot of irrigation, use new drills so they're very sharp. And also, because there is no trabecular bone in that area, it actually gives us less surface area for bone to implant contact. So we know that trabecular bone has more osteoblasts than cortical bone. So then the bone remodeling and bone regeneration process starts and is a little bit slowed. So what is our recommendations on these hyperdense lesions? As you can see, here is one right here on the apex of this bicuspid. We want to avoid it. Ideally, we place the implant and avoid the lesion if we can. If not, if it is right in the center of the area, as long it is as if it is non-active, then we can go ahead and place the implant. What are we going to do surgery-wise? We're going to use, as I said, sharp new drills, copious irrigation. Also, when we perform the osteotomy, we're going to bone dance, drill in and out, bone dance to let that irrigation get down into the osteotomy site. And be very, very careful that when you insert the implant, that you don't have too high of an insertion torque where you're going to get a pressure necrosis. And prosthetically, because that osteosclerotic area takes longer to heal, we're going to give it a lot longer to heal before we load it or possibly progressively loading it. So in summary, when we have a hyperdense bone, there really aren't any contraindications unless it is an active lesion, which I went through a couple of them. If it is just sclerotic bone or condensing osteitis, then you can place the implants if you can't avoid it. However, our ideal treatment is to avoid these lesions. If we do place through the lesion, we're going to make sure we're going to use a D1 surgical protocol. So use our D1 surgery protocol so that you don't put too much force in the performing the osteotomy where you're going to get necrotic bone. If you want more information on more of those sclerotic lesions, in any of the textbooks in the radiology chapter, I go over all those and I give the recommended protocols. But you will see these. Again, ideally, you avoid it. If you can't avoid it, as long as it's not active lesion, it's condensing osteitis or idiopathic osteosclerosis, you're fine. You just have to modify your surgery protocol. With that being said, I am going to send it back to Hussein because we have 12 cases and I want him to take over. So go ahead, Hussein. Do you have the screen?
Yes, sir. Got it. Thank you so much, Dr. Resnick. And first case for today, sir, is for Dr. Ahad Saqib. Dr. Saqib, would you mind unmuting yourself, Doc, and presenting your case to Dr. Resnick? Uh, Go ahead, Doc.
Absolutely, Hussein. Thank you
Hi,
so much for
Doc. How are you?
good. How are you, Dr. Resnick? Thank
Good, good.
so real quick, this patient, she has a chief complaint that, she'd like a nice smile. And so I said, okay, let me think about it. And I wanted to do two implants on 23 and 26. And then just do like a bridge, implant bridge.
Okay, so could we do a 360 here? So he's going to just show us the 3D model. Let's look from the lingual. Okay, so we have very, very thin bone there. Okay. And let's go ahead and look at the pan view.
You got it, sir.
Okay, good. And let's go through the cross sections. So he'll start on one side and just scroll through. So look at the cross sections. So that is actually Doc Division B,
Mhm.
borderline Division CW ridge. Okay. So with that being said, now, first of all, it looks like the CT was cut off. So those teeth aren't that small, are they, Doc?
No.
Okay, so it's just a CT scan, where the patient was positioned.
Yeah.
So that's not a problem. We can still treatment plan this. Hussein, did you treatment plan the 2 implants?
Yes, sir, I did. I did add 2 implants at the size of number 23 and 26. I'm using a 3.5 by 11.5 Hon tapered implant for each side of these, Dr. Resnick.
Okay, let's look at the pan view on this.
You got it, sir.
Okay, so you put those in the embrasure, right?
Yes, sir, I did.
Yeah. So, Doc, where he put these implants is in between 23 and 24 and 25 and 26. The reason why he didn't place them right at the 23 and 26 is, do you see those circles that the red circles?
Mhm.
What would end up happening if you get the implant too close to the mesial, the cuspid, the bone would resorb, and then you would have a bony defect on the mesial of those canines. So usually with the lower anterior, when we're missing 4 incisors, we do 2 implants in the embrasure, but they're coming through in the cingulum area, so it'll be a screw retained prosthesis. Okay,
Yeah.
does that make sense?
Okay.
Doc?
Yeah, it makes sense.
Okay. So the other thing on this case, though, is doctors saying, yeah, there's not enough bone to place the implants. So even where you have them positioned in the vertical plane, there, I mean, you're going to have at least 4 or 5 millimeters of the implant exposed there. So, Doc, here's what I'm going to recommend. Let's go back. Let's look at the other implant. Just look at.
Yes, sir. That's
Oh,
number 26,
oh,
Dr.
that's
Resnick.
even worse. Okay. Yeah. Okay. So, Doc, what I would recommend phase 1 is going to be a bone graft. So, GBR with delayed implant placement. That will be with the, have you done the S3?
I'm a fellow, Doc. I've
Yeah,
done all the surgical
you've
stuff.
done all of them. Yeah. So, if you remember S3, this would just be the tent screws.
Okay.
And this would be a GBR, build it out, and then come back and place those 2 implants. It
Got it.
would be, this is more like, do you remember I talk about a catcher's mitt?
Yes.
This is a good catcher's mitt. So this is a good one. The only problem that you might have is getting primary closure here, because if you see that ridge is very, very thin. So what I want you to do is err more on the lingual when you make your incision, so you have a little bit more tissue on the facial. So if you make your incision on the lingual part of that crestal, the ridge, and then you just push it over, you'll have a little bit more, and you'll be able to stretch the tissue a little bit easier. Okay?
Gotcha.
Does that make
Randy,
sense?
makes sense. I
Okay.
have a quick question for you. So
Yes.
this is like I might refer her because she's kind of not been nice to my staff. And
Okay.
it kind of tells me that if I even make a small mistake, like on something like this, she might like come after me. What are your thoughts?
Recording.
Well, I tell you what, Doc, if you have a reservation on this patient that she is going to be a maintenance issue, and have you done any grafts like this before?
I've done 2 or 3 so far.
Okay. This is going to be a little bit more challenging because again, the primary closure is going to be the big thing, and you have to grow on this implant here. You're going to have to grow about 3 millimeters of bone. So I mean, if you have any reservations, there's a lot easier GBR cases definitely to do. So I don't I wouldn't fault you at all if you wanted to refer it and then get it back and place the implants. Yeah.
Got it. Okay.
Yeah.
Thank you,
Okay.
doctor.
Okay. Take care. Have a good night, Doc. Okay, let's go. Number
Next
2.
case, sir, is for Dr. Cole Washington. Dr. Washington, would
Oh,
you mind
Dr.
unmuting yourself?
Washington, how are you?
I'm doing good, buddy. How about
Hey,
yourself?
haven't seen you in a while. How have you been?
I'm doing good. I'm actually in the Keys right now, so sorry that I'm not on the
Oh,
screen
you're
there
always on vacation. Okay.
yet. Yeah, I'm just smelling like fish. So,
Okay, there you go. So what do you have for us tonight?
so I've got a 68-year-old female that we did a long-spanning kind of herodonics bridge on her, and
Okay,
it broke the post right at number 11,
11.
halfway
Okay.
down. And so I was looking at trying to do some implants in the area, but we have a sinus that's getting kind of close. So I was going to get your thoughts on it.
Okay, so let's look at a pan view of this, Hussein.
You got it, sir.
Okay. So if we look at the pan view, okay, so the cuspids broke off, and then yeah, so you're looking at 11, 12, and 13, Doc.
Yes, sir.
Okay, so let's look right at number 11. Let's do a cross section number 11 and see what we
Here,
have. Okay,
here you go,
Doc,
Dr.
were
Resnick.
you thinking of doing this immediate?
I'm not all the way sure. I was going to
Okay,
gauge it.
can I help you out?
Yes,
No.
please.
Okay, so there it's already perforated. So number 11 is, see where it's perforated through the buccal plate?
Yes, sir.
This is going to be a little nasty to take out. When you do take it out, you're not going to have any buccal plate there. Even though, as you know, this would be an ideal case because we have 2 to 4 millimeters apically and we have a lot of bone lingually. However, that tooth, once that comes out, you're not going to have much at all. Also, so I would probably take that out, graft it. Now let's go more distally, because did you say you want to do an implant in 11 and 13, Doc? Is that what you said?
I was leaning more towards doing one in 13, but yeah. So doing one in 11 and 13.
11 and 13.
Right.
Okay. So that's number 12, which is all right. Let's go to 13. Okay.
Here you go. That's 13 area, Dr. Resnick.
Okay. Hussein, did you treatment plan this case?
Yes, sir. I did plan it for 3 implants, Dr. Resnick, at the size of number 11, 12, and 13, sir. Right now, the one I'm on is number 13 side. And the native bone we've got over here, Dr. Resnick, is approximately 3.7 millimeters over here to the
Okay.
palpebral bone. And to the facial aspect, sir, if I take my measurement from over here, we've got pretty much like 5 millimeters of bone to the facial
Yeah.
aspect. Go ahead, sir.
Okay, so Cole, remember we always measure from the least amount of bone. So if you look at that on the buccal, you have 5.1, but on the lingual, you have 3.7. If you remember, we need 5 millimeters of host bone to do an SA3. So I would say this would be actually be a very easy SA4 for you. So
Okay.
see the inflammation on the membrane?
Yes,
So
sir.
see how you have about a millimeter, maybe millimeter and a half of inflammation? This is a perfect case for you for a sinus graft. So let's
Okay.
go back to the pan view of this.
Yes, sir.
So to review this, Cole, that cuspid, like I said, that's going to be wicked. You make sure that you curette this. I would probably, here's what I would do, Cole. I would do the sinus graft and take that tooth out at the same time. The reason is you can flap that whole area. You're going to have to flap down onto the buccal there where that's perforated through
Okay.
and clean that out. So go in with a small little round burr and really decorticate it and get, you have a little bit of tissue there from a PA lesion. So you're going to have to clean that out. So
Okay.
that and your graft would be very easy because, like I said, you know where you have a tooth behind it. So that's kind of your backstop. It'll be a small window. Rather straightforward sinus. So
Okay.
if you want to do that, just get in contact with me and we'll walk you through that one.
Okay.
Okay. Questions on that?
Yes, sir. As far as the 2 implants versus the 3, what's making y'all think 3 would be a better option?
Okay, so why Hussein put 3, and I believe I'm talking for him, is that just so we had one in so he could show us. Now, as you know, when you do 2 implants versus 3, it all depends on force factors and local factors. So, number one, is this patient have parafunction?
Yes, sir. Yeah, she broke a zirconia bridge twice.
Oh, okay. Then you need 3 implants. So,
Okay.
so the other thing is, Cole, remember, look at that back implant. You're going to have a 8 millimeter implant that half of it's going to be engrafted bone. Do you want that as your distal abutment? Remember, you have as the patient is bites 5 to 1 comparing the posterior to the anterior. That's a lot of force. I definitely do 3 implants, but
Okay.
I would do all the implants at the same time. So do the sinus and the extraction at the same time. The phase 2 would be all 3 implants. Yes.
I will.
Okay.
Thank you very much.
Okay. Enjoy the keys. Okay. Take
Yes,
care.
sir. I will, buddy.
Okay. Okay. Let's go. 9
Next
more.
case, sir, is for Dr. Kenny Robles. Dr. Robles, would you mind unmuting yourself, sir?
Oh yeah. Hi, Dr. Resnik.
Hi,
How are you guys?
Doc. How are you?
Very good. So we have he's early 50s. He's a healthy individual, but his teeth has failed on him.
Okay.
He thinks he's gene, but he doesn't take care of his teeth as much anyway. So at this point, we are most of his teeth are either hopeless or they have a very poor prognosis. So we're trying to do an all on X
All on X.
case.
Okay.
Yeah. So what I'm
So,
thinking is remove the teeth, have him on an interim, remove the teeth, do alveoloplasty, um, and then have him on an interim
okay.
denture.
So when you say all on X, Doc, were you thinking of immediate placement, immediate load, or were
No,
you
no.
delayed?
What I'm
Okay.
thinking is, what I'm thinking is removing his teeth, do my alveoloplasty, have things as flat as possible,
Okay.
and then give him a denture that day so that he
Okay. No,
lives with
I
two.
agree with you 100%. First of all, Doc, with the amount of pathology here,
Mhm.
you have to be very, you have to really clean this out.
Number
So,
number 11 was already removed, and I
oh,
cleaned it
was
up.
okay.
Yeah, 11 was
So,
removed. Yeah.
so with all this pathology, I would clean it out. If it looks like you should be able to do that, so that shouldn't be a problem. I graph the sites. Remember, your most important sites are your canines, your molars, and then your bicuspids. So make sure you clean that out. The only thing is, Doc, to do a fixed prosthesis on this is most likely going to be a bilateral sinus graft case. So it'll be an SA4 on both sides. Okay. And you might even need a little bit of ridge augmentation. So here's what I would explain to the patient. Phase 1 is you're going to extract the teeth, remove the infection, do the alveoloplasty, and graft any of the sockets that you can. Then 3 months after that, you're going to take a CBCT and you're going to evaluate those key implant positions. There's a possibility you might have to do secondary grafting, meaning you might have to do some GBR. You'll definitely need to do sinus grafting to get implants in the molar and the bicuspid area. The reason why I want you to make sure that you write that in the treatment plan is so the patient doesn't think that original bone graft, which is socket grafts, is actually going to be the definitive bone graft, which is the GBR and or the sinus grafts. Does that make sense?
Total. Yeah, that makes total sense.
Yeah. So clean this up. I would also start the pay. Is the tissue pretty bad on this? Is
It's
it
not excessively bad. I mean, 11 was bad because, but
okay?
I already removed that. I cleaned up, and right
Okay.
now,
It probably wouldn't be a bad idea to put the patient on chlorhexidine a week or two
a
before the
week
cert.
prior. Yeah.
Yeah, and then also I would start antibiotics on this patient, probably a couple days beforehand. eh, Hussein, remove the teeth for me there. Let me just see
Yes,
what's
sir.
left there. Okay. Yeah, I think if you socket graft, especially, again, well, yeah. Some of those molars are really badly infected. So I would just socket graft at least the first molars in the canines. I'd even do that anterior segment also. Okay.
Yeah. How about the lower arch?
Okay. What's going on in the lower? Do we have the lower, Hussein?
And I didn't have the lower, but
Oh,
I
okay.
could
I
really
just,
trace
yeah,
the
well, we only
manners
probably
or
for,
really.
yeah, I mean, the main thing is the upper arch, but for the bottom, I'm thinking something similar,
Okay.
in
Now,
terms of like the concept.
were you removing all the lower teeth?
Yeah, that's gonna be we're thinking about upper arch first because there's also
Yeah.
some financials
Oh,
that
there. Okay. So, so Doc, see how those anterior teeth go uphill? So
yep.
you've had some super eruption there. You could do very easily an immediate extraction, immediate placement on this because you'd be doing a alveoloplasty almost to the roots of those teeth to get you restorative space. And
Yeah,
the infection isn't that bad on the
it's not
bottom.
as bad.
Yeah,
And
yeah.
going back to the maxilla, you're thinking about 6 implants over there?
Yes, 6 implants, possibly 7, depending on the arch form. But
Yeah.
I would definitely do 6 implants. It's going to be in compromised bone. I think that would
So
be more ideal. And
so
it's going
it'll
to be
be
opposing. Oh,
mhm.
do you have implants in? Oh,
Now these were just mock-up implants, Dr. Resnick. I was trying to add over here to find out if I could add any implants, sir.
oh, okay, okay.
So
Oh,
it'll be
go ahead, Doc.
essentially what area of number 314,
Yeah,
both canines.
yeah, so remember, you want canine implants because of
Yeah,
cuspid
the
rise.
one canine.
You want molar implants because molar and second bicuspid, so there's no cantilevers. That arch form, Doc, looks pretty square to me, so you
Mhm.
probably don't even have to go into the anterior. But I would still graft it just because of your
Yeah.
transition line with your zirconia prosthesis.
Yeah. All right.
Okay.
Thank you so much, guys.
Okay,
Thanks.
Kenny. Thanks. Take
Okay.
care. Okay.
You too.
Okay,
Next case,
Hussein, let's
sir,
go. Next one.
Dr. Gerald M. Jijofa. So, Dr. M. Jijofa, would you mind unmuting yourself and presenting your case to Dr. Resnick, please?
Hello, Dr. Resnik.
Hi,
I
Doc.
have
How are you?
a 45-year-old male who at 11 years old fell off the swing and he has a couple of plates in the jaw right now. And when I saw him, he's number 8, huge abscess. So here he presents to me, and I was thinking he has a huge maxillary defect. I was thinking I need to extract that 8, maybe do an apical on number 10 and graft the whole buccal area, and then in the future, if I can, do some implants, but there's all of
Okay.
these plates there.
Wow. Okay, so Doc, let's go over this. You have number 8,
Correct.
number 10, and 11. Okay. 8 and 10 do not look real healthy, do they?
No, 8 is just sitting there in infection, and 10 I
Infection.
think it has a like a smaller periapical lesion, and
Yeah.
since it's going to flap that the whole anterior, I was thinking if I can try to save it and
Yeah. Okay. How about 11? What condition is 11 in?
11 didn't look too bad to me.
Okay. Okay. So we're basically, let's go back. Let's go to the pan again.
Yes, sir.
Okay, Doc. Well, first of all, with the infection on 8, that needs to be completely cleaned out and grafted. That is such a large defect. Wow, I don't even know
And clinically, it's just massive.
yes.
I was thinking if I need to do that titanium 3D printed, to get
Well, well, the first thing you're going to do is you're not going to be doing a GBR on that right off the bat. So this is going to be phase one is going to be take out the teeth, take out the infection, and possibly socket graft if you can. I believe, Doc, doing an apicoectomy on number 10 probably wouldn't benefit you much. 10 is not that good of a tooth. It has a pretty large lesion on it. So I would take out 8 and 10.
Mm-hmm.
Also, if you keep 11, 10 is going to be one of your abutments there. So I would rather have that as an implant. So if you look at 7, let's look at number 7, the cross section, and see what that
Right,
looks like.
right away, sir. And here we go, Dr. Resnick. So the bone is
Oh,
very
there's
thin.
no bone there.
Yeah.
Okay. Yeah, Doc, I'll tell you what, this is going to be on a scale of 1 to 10 difficulty. This is a 15. Okay. That you're not going to have much bone at all there. So, here's what I would do. The patient has a pretty significant active infection. Look at number 10. There's no buccal plate there, Doc. So,
Mm-hmm.
so that needs to be taken out. I take out 8 and 10. Completely enucleate these lesions and clean it out and then rescan it and let's reevaluate it. There's a possibility that this might be one of those cases that may not be even graftable because
Mm-hmm.
I think, first of all, you have almost no bone in number 7. We couldn't even put tent screws in there. So you might be looking at like a block graft. But I
Mm-hmm.
think first things first, this patient has a really significant infection. I think that needs to be addressed immediately. And then after everything heals, come back, take another CT, and let's reinvestigate it. How's that?
After I extract everything, would you recommend, I was thinking, a snap-on smile or smile
I,
transitions with Gladwell?
Smile transitions 100% of the time. I was just going to say that
Yeah,
because this would be a perfect case for it because you have enough posterior teeth
right.
and you could, it will allow that to heal very nice, especially if we do like a big graft there later. So definitely a smile transition on this case, I would do. Yeah.
And so for the patient in the future, don't give him any hope for any implant supported.
Well, no. I would say that the extent of the infection may contraindicate implants in the future. However, you do not
Pick up your
know.
left leg
And,
for me.
until
Oh,
everything
okay.
heals, you won't know. So take out the teeth and let them know that you're going to take a scan in 3 months. And at 3 months, then you will decide on what the actual treatment's going to be.
All
Okay.
right, let's do that.
Okay.
Great,
Okay.
thanks. Good.
Okay,
Thank
Doc.
you.
Take care. Have a good night. Okay.
Next
Okay,
case,
Hussein,
Dr.
let's go
Resnick.
for it.
Dr. Berna, sir. So, Dr. Berna, would you mind unmuting yourself, sir, and presenting your case to Dr. Resnick?
Yeah, hi everybody. Can you hear me?
Yes.
Loud and
How are
clear,
you,
Doc.
Doc?
I'm doing well. I have a feeling your initial talk was about my case with the sclerotic lesion,
Yes.
but
Yes, it
yeah,
was.
yeah,
I knew
that
that
was why.
I knew we had one case and Hussein told me and then I said I saw 2 of these this past weekend, so that
Yeah,
little talk hopefully made sense. So
it did.
Hussein?
It answered a lot of my questions. The only thing I'll add is just 40 years old. She does have some medical history stuff: osteopenia, hyperparathyroidism. She takes a lot of like psychiatric meds, but none that are like SSRIs technically.
Okay.
But I did graft the site already after taking out a couple teeth, 12 and 13. So just the lesion was there before,
Okay.
and it looks about the same. So I just wanted to see how you'd approach.
Okay, so let's see let's look at a pan view of this.
Right away, sir. Here we go.
So we're looking at 2 implants, 12 and 13, correct?
You got it.
Okay. So Hussein, did you plan implants for this?
Yes, sir. I did add 2 implants at the size of number 12 and 13, Dr. Resnick. Starting with number 12, sir, I'm using a 3.5 by 13 millimeter long implant. good bone coverage to the facial and to the palatal, doctor, leaving 1.5 millimeters to the laminitic adjacent tooth, 3 millimeters in between number 12, 13. 13 is a 3-5 by 10, sir, engaging the bone over here, engaging the cortical bone of the maxillary sinus, and engaging the lesion over here to the distal aspect. That's the 2 implants I added for this case, Dr. Resnick.
Okay, so Hussein, can you make 13 an 8 millimeter?
Yes, sir. Here we go.
Yeah, it was threading the needle a bit.
Yeah.
I was able to get a couple in, but it was tight for
Yeah,
sure.
so Doc, here's why. This is one of those idiopathic osteosclerosis cases. So
Hmm.
this is a situation that we're going to have to engage it, but we don't have to go through it. So
Hmm.
by going 2 more millimeters isn't going to give us any more primary stability. If you look at the superior 5 millimeters, the top crestal 5 millimeters, you have pretty good bone quality there. So I'm not worried about the primary stability. The
Sure.
only issue you're going to have is when you, especially on your first drill, the 1.5 drill, it's going to be rather significant drilling into that. So just bone dance real well. You're only going to, and you know what, Hussein, could you just cheat that over a little? If you maybe just tilt it a wee bit, go a little bit towards the other implant, and then tilt the apex towards the other implant. So
You got
just
it,
do
sir.
one click. There you go. And now tilt the implant. Okay. Now, that means we're too close for 3 millimeters. Do one click on number 12 anteriorly. Yeah, you're
Yeah,
3.
yeah,
You're fine.
yeah,
You're fine.
we're fine.
So Doc, I would do this guided. This would be a slam dunk. Just remember, you're gonna probably have to do a little enamel or a porcelain plasty on that crown on number 14. But I think that
Definitely.
would be this will be pretty simple for you. So no problem.
Awesome. Appreciate
Okay.
it, Doc. Thank you.
Okay. Nice case. Nice case. Okay,
Next case,
Hussein.
sir. Dr. Asper Johnson. Dr. Asper Johnson, would you mind unmuting yourself, Doc, please, and present your case to Dr. Resnick?
Hi, Dr. Resnik.
Hey, Katie, how are you?
Good. How are you?
Aren't you tired of listening to me? You've been listening.
Not at all.
Okay. Okay. What do you have for us tonight?
I have a 76-year-old female. I'm looking at taking out 13 and hopefully doing an immediate implant. She has type 1 diabetes. Her last A1C was 7.1. She does have osteoporosis and gets Prolia injections every 6 months, and she's on Prozac. Um, that's about it
Okay.
for her med history.
Okay. So while he's getting that up, let's go through it. Prozac SSRI. It's not a absolute contraindication. It's a relative contraindication. Just let them know that there is a higher incidence of implant failure. It's not
Okay.
that significant, but it's enough that you should inform the patient. Secondly, remember Prolia is a monoclonal antibody, and we try to time that in the 5th month
Mm,
of their last injection. So see when their last injection is. Ideally, it should be approximately the 15th day of the 15th month. However, I would get medical clearance from a patient's physician. Some physicians will recommend that you do it during the 5th month. Other physicians will say not a problem. And the failure rate is not real high. It's rather low, but it's again, you have to inform the patient of that. So I would see what the
okay.
physician says on
I
that.
Yeah, I did. This was one I emailed you about. So I did send
Oh,
a
you did?
medical
Okay.
clearance, and her doctor, her her GP wasn't familiar with the that protocol where
Okay,
you
that
do it in the
protocol.
5th month.
Okay.
And so
Yes.
they consulted with her endocrinologist, and they came back around and pretty much was like, you can do whatever you want to do. And so that's why I was talking to you to see if the doctors are like, well, we don't really care, would you just automatically do it in that 5th month?
Wait, yeah. Do you know when her last injection was?
She's due in September.
Oh, in September. Okay.
Hmm.
So the longer the
September or
closer
October.
the closer you get to September, the better. The reason why those studies show the 5th month, 15th day is the blood levels are the lowest because of the half-life of the drug. So
Okay.
again, I think it's more important that you have an informed consent. And remember, Katie, I have a special consent for monoclonal antibodies. So just use that. So I think you could go ahead and do it anytime, especially if
Okay.
you have both physicians on board and it's a single implant. You're not, if this was a sinus graft or a large GBR, I would probably say wait. It's a single implant, small incision, not a big deal. So
Okay.
yeah. And then what else? It was 7.1. They're on
A1C of 7.1, Prozac.
and they're on
Yeah.
metformin. Is that what you said?
Nope.
Metformin?
No. No. I don't think she's on. I don't think she's on anything else.
Oh, yeah. What is she on for the diabetes?
Well, I don't know. I don't have that written down. So maybe she's on something.
Oh, wait, I see it on the list. Humalog. That's insulin.
Oh, okay,
So
Humalog. Okay.
okay, so she is an insulin controlled diabetic. So
Yes.
did you ask the physician what the patient's A1C, the history was?
Not the history. I just got her last one, but I could ask for the
Okay.
history.
Yeah, let's do this. The problem is, Katie, insulin controlled diabetics are a little bit different. If they're 7.1, I just don't want to make sure they were 7.8, 3
Okay.
months ago. So usually they're pretty stable, but let's just make sure. Ideally, you want them around 7. Um, a lot of these patients are insulin resistant. So
Mhm.
their A1Cs are going to be a little bit higher anyway. But if you have this patient around the 7, I think you're good to go. And
Okay.
again, it's only one tooth. So with all that being said, let's go and let's look at the cross section here. So what do we
So,
have, Hussein?
So we've got an immediate implant placement at the side of number 13, sir. And here we go. That's the root of tooth number 13, Dr. Resnick.
Okay. And did you place an implant?
Yes, sir. I was able to add an implant mesial to the root of number 13, engaging better native bone outside
Okay.
of the extraction socket of that tooth, Dr. Resnick, just enhance the primary stability of this implant. What do you think, sir?
Okay.
That's a
I
3-5
tell
by
you,
30.
Katie, this is exactly what we talked about this past weekend. So this will be an ideal immediate case for you. The
Okay.
only issue that I have, Katie, is this female or male?
Female.
Female. Okay. Do you have a virtual tooth on this, Hussein?
Yes, sir. I did add a virtual crown over here and period, Dr. Resnick.
Okay. So this crown's going to be an FP2, Katie. So just
Okay.
explain that to the patient.
Okay.
It's going to be a little bit longer than the adjacent teeth.
Okay.
Do you have a frontal view on that? Any type, just so she can see what I'm talking about
I
here.
think I could switch on the bone mask, sir, and
See what I'm, but
Yeah.
you know what? Her molar, she has bone loss on the molar anyway, so
Mhm.
it's going to be similar to the molar. Okay.
Okay.
But I like you, and also use that consent form of mine for implant surgery. And this is a perfect case because it explains that it'll be a little hyper contoured. So,
Okay.
yeah. So, Lindemann drill, lingual
Mhm.
plate, just how we did it. Okay.
Okay.
You'll be good to go. Okay.
Okay.
And let me know if
Perfect.
you have any questions on it. Okay.
Okay. Thanks, Dr.
Okay.
Resnick.
Take care, Katie. Okay.
Thanks, you too.
Okay. Bye. Okay, Hussein, let's go.
Dr. Kuzman, that's your next case, sir. Please
Dr.
unmute yourself.
Kuzman.
Hey,
Dr.
how you
Kuzman never has an easy case for me. Did you bring me like an easy one?
No, I
Really?
did not.
I know. It's
P-
impossible.
Yeah, patient's a 75-year-old with some chronic rhinosinusitis. Ugh.
Okay.
He's got a little high blood pressure. We've had him cleared by ENT. He went back. He had some therapy because he had a lot of thickening, and the new scan shows it's minimal. He presented with 2 RP5s, one on the upper, one on the lower. The one on the upper, bunch of implants failed because there was no palatal support. So we're left with 2 implants on the top. The lower the implants were placed without any consideration for restorative space. So
Okay.
I think we've
So
got a little
Frank,
bit
I'll
of
tell you what, why don't we, because he can only put one up at a time.
Okay.
Let's look at the maxilla. Let's look at a pan view of this. Okay. So let me see, what do we have here? So there's 2 implants. Now, this patient came in with 2 implants, right?
He came in with 3. I had to
Okay.
remove 1 and graft. But
Okay.
I left those 2 in because they're pretty well integrated, and I'm just wondering if we can still use them.
Okay, so what is the history on, it looks like sinus grafting was done.
Yes.
Okay, was that recent?
6 months.
Okay. Okay, so let's first look at this right sinus. So Hussein, can you give us cross sections through the right sinus?
Right away, sir. Here we go.
Okay. Okay, now let's go over to the left sinus and do the same on the left.
Here with
So
the
he's going to
left.
scroll through the cross sections. Okay. Okay, let's go back to the pan view of this.
Here you go, sir.
Okay, so Frank, let's first look at the sinuses. So the right one, we could get an implant in the molar region. So Hussein, show him that. Did you place an implant in this, Hussein?
Yes, sir. I did attempt adding like 4 implants over here for this case, starting with where the sinus lifts were done, and that's going to be implant number 3, Dr. Resnick. I added a 5 by 11.5 limited long implant over here, sir.
Okay, so how many months ago did you do these, Frank?
6.
6 months. Okay. Some of that bone didn't turn over. You can see in the anterior where the bone has been lost. Okay.
Right.
We could get an implant in there. That's just very poor bone density. So you would have to D4 protocol on that. So
Okay.
let's keep going. Let's go to the other side.
That's
And
number 14, Dr. Resnick, a 5 by 8, and there's some soft tissue infiltration over here with that sinus
yeah,
lift, sir.
yeah, doc. Okay. So Frank, here's the
Yeah.
problem on the left. There's an oral antral fistula. Do you see that?
Oh, okay.
Hussein, here, show
Sir.
everyone where. Can you mark that somehow or?
Right away, Dr. Resnick.
So there's a fistula.
Okay.
So
All
what
right.
happens? Sometimes you'll get a communication.
Right.
Usually 5 to 7 days. If the communication doesn't close, it'll fistulate, which means it's epithelialized.
Right.
Yeah, I don't think an implant on that side is going to have a high success rate. So let's look at the implants here. Can you do cross sections through both implants?
Definitely, sir. I'm going to start with number 3, Dr. Resnick. Here you go.
I'm sorry, the existing implants.
Definitely, sir.
Because he wanted to see if they were salvageable. Can you blow that up for everyone? Okay. Okay. That one has a little bit of bone loss, Frank. Scroll back and forth.
Right.
It's not bad. That one's all right. That one's all right. Let's look at the other one. Okay, that one's all right also. It might be causing, part of it is in the sinus there, so you can see the thickening in the sinus. But you said this patient has chronic rhinosinusitis,
Yeah,
right?
he's a woodworker who refuses to wear a mask.
Okay. Okay, so let's go to a pan view of this. So Frank, here's what I'm going to recommend.
Okay.
I'm not 100% comfortable with the right side, and I'm not at all comfortable with the left. The left is going to have to be definitely redone.
Okay.
The right, I'm gonna say we should probably go in and repair that. See the anterior, show him the anterior
Yeah.
part on the right side, Hussein. See where it's all radiolucent? Can you
Yep.
mark that,
Oh,
Hussein,
that
so everyone
definitely,
can see
sir.
it? So Hussein will mark this. So the problem that we're going to have here is, can you mark it with red or anything so
Yeah,
people can?
it's just giving me a technical error with my
Oh, okay.
side.
That's all right. That's
Yeah,
all right. So you can see the radiolucency there. So the
Yeah.
problem is a mucociliary action there is going to be compromised. And even in the, hold it right there. See, you have voids in that bone graft. So it might
Okay.
be just as easy to, when we repair it, add some bone into that also. So here's what I'm going to do. Just because we have limited time, I'll
Yeah.
talk to you. Uh, we'll talk about this week,
Okay.
and this is going to need some remediation.
Okay.
So we're going to need to take a step back on that maxilla. Let's look at
Okay.
the mandible real quick. So you
right away,
said
sir.
something, there were implants. They look like they placed them without doing an osteoplasty, so they're rather
Correct.
high. Okay.
Correct.
So and how old are these implants? Do you know?
About 5 years.
Okay. And how is the prosthesis working for the patient?
The prosthesis is not staying in well. Well, if you look at the midline implant, it's not in any bone, so that one definitely has to come out. And that's where the problem comes in. If you take that out and then try and place an implant, it's going to be lower than the
Yes, because they're all too high.
yeah.
Okay. Okay. So let's take a look here. Okay.
I'm gonna
So
start.
yeah,
Go
why
ahead,
don't
sir.
you scroll and everyone can look at the cross sections? Okay. Oh, so you have a
Yeah.
perforation. What
Yeah.
what number is that one?
I think that's number 20, 19 or 20, Dr. Resnick.
Okay. Okay, keep going.
And then we're gonna get our midline implant, which is that one.
Oh, ow. Okay,
Yeah.
that's not good. Okay, keep
Yeah.
going.
Last implant, sir, is the one to the right side.
Okay. Okay. So let's look at a pan view of this.
Sir.
Okay, so here's what I'm going to recommend, Frank, on this.
Okay.
Okay. Scroll through a little bit more so they can see all four of the implants or five of the implants. Okay. So, see this implant in 21? It's perforated.
Yeah. I think 20 is also perforated if you look at it.
Yeah. So here's what I would do, Frank, on this case. You do not want to be taking those implants out. That would get very dangerous.
Okay.
You could end up with a mandibular fracture on that case. So
All
what
right.
I would do is take the abutments off, and I would just sleep these implants, meaning
Okay.
you
Yeah.
just fill the internal configuration with composite,
Okay.
and then you just polish it down and leave them in there. Let the
Okay.
patient know that it would be more traumatic to remove them than just to leave them in, and they'll probably never cause a problem. But if you try to take it out, that's going to be a mess. The other
Okay.
three here,
Mhm.
those need to be taken out. You need to do an osteoplasty of about probably 5 or 8 millimeters, and then do anywhere from 2 to 5 implants do they want an overdenture?
He's looking for FP3.
Oh, you're doing FP3. Oh,
Yeah.
okay. Oh, then you know what? Maybe you could save those implants on the left then. Okay. I thought you were doing an overdenture. Okay.
No. No.
So for a fixed prosthesis, there'll be enough room once you take those abutments off and you go right to the implant body with the
Okay.
prosthesis.
Okay.
So you will have a different vertical level because you are going to do an osteoplasty in the anterior, but you'll have a tissue level abutment. So you'll bring the implant level up to the tissue level.
Okay. Okay, so that'll
Okay.
be okay.
Yeah.
Okay.
So what I would do is do an implant in the A position,
Okay.
B position, and then maybe AC, maybe AC and D position. That might work. So 3 implants. And why
Okay.
don't we work this one up too? Okay. So
Okay.
don't do this case until Hussein and I look over it a little bit more.
Okay.
Okay.
All
It-
right.
Yeah, that will work. And so don't cut those implants off. Leave them there. It'll be good for a fixed prosthesis. Yeah.
Okay. And then the top will talk.
Yeah, we'll talk. That's going to need some remediation there.
Yeah, I kind of figured that it wasn't it was he was hard to do the
Yeah. Yeah.
sinus.
And with chronic rhinosinusitis, usually they're not healthy
Yeah.
sinuses to deal with, so they don't adapt very well. So
Okay. All right.
okay.
All right. Thanks, Randy.
Okay. Okay.
Talk
Take
to you
care.
soon. All right.
Okay. Okay, let's go. Hussein, next one.
Dr. Emily Nider. Dr. Nider, would you mind unmuting yourself, please, Doc, and presenting your case to Dr. Resnik?
Is she there?
Sorry, I was trying to unmute. I'm here.
Oh, okay. Okay.
Hi.
Hi, Doc. How are you?
I'm good. How are you?
Good, good. What do you have for us tonight?
Okay, so my patient is 40 years old and she's female. Medical history is depression. She takes Lexapro. When I first saw her, which was about a month ago, number 12 was unrestorable and a lot of pain. So we took it out and I did socket preservation.
Okay.
And then she came back this week for a full exam. So that's why we took the cone beam. And number 4 has been missing for an unknown amount of years. So I was just wanting kind of opinion if we had enough width for
Oh, okay.
4.
Okay. Well, first of all, it looks like you did a nice job on the socket graph. So let's
Thanks.
look at number 12 right off the bat.
Okay.
And let's look at a cross section and see what we have.
This was my first socket preservation ever.
Great. Oh, that's perfect.
Yeah.
Okay. So do you see where the bone is integrating with the host bone? How long has it been, Doc?
30 days.
Only 30 days?
Yeah, she's a really good healer.
Wow. That's like over the top healing. Okay. That's unbelievable. That looks great. What type of bone did you use?
I used the osteofiber.
Osteofiber. Great.
Mhm.
Great. Okay, Doc. Do you remember me talking about number 12 being, first of all, have you done many implants?
No, I've never done one.
Okay, this is your first one. This is the best one. Oh, this is great. So everyone on this webinar, this is the ideal first case. There's tons of bone. There's width and height. Let's look at the 3D image of it.
Yes, sir.
If you look straight in, I mean, this will be very, very easy. My recommendation, Doc, is you could do this completely freehand, or if it's your first case, have them make you a pilot guide where you just drill the first drill through the tissue, and that gives you your mesial distal buccal lingual, and then you flap it, and then you proceed freehand and place the implant. This one will be easy, simple, and definitely do that one your first case.
Okay.
Great case. And just make sure that I see it before when they plan it. Okay,
Okay.
after they plan. Okay, let's go look at number 4 here. And this is the one that you don't know how long it's been edentulous, right?
Correct.
Oh my gosh, this is perfect. Great. Another great case. You have tons of width and tons of height.
Okay,
So
perfect.
no problem. Hussein, I would treatment plan probably 4 3s on both of those. And
Yes, sir.
yeah, send those over to me. And Doc, this is a great case. Great case. And get ready to do it.
Perfect. Thank you so much.
Okay. Any questions on that, Doc?
Nope. My only question was if you would like do it flap or flapless, but I think
Yeah,
I
you
like
know
the
what?
idea of doing it partially guided for my
But
first.
do the pilot guide.
Yeah.
It makes it so easy. And then you also build up your surgical skills. That's the best way to do it. So,
Okay.
and I'll walk you through it. Okay.
Okay.
Just make
Perfect.
sure they contact me on it before you do it.
Okay.
Okay.
Yes,
Thank
sir.
you.
Okay. Take
Awesome.
care.
Next case, Dr. Resnick, is for Dr. Carnu. Doc, would you mind please unmuting yourself and presenting your patient to Dr. Resnick?
Hello.
Hi, Doc.
My
How are you?
I'm fine, thank you. My patient is a 63-year-old female, healthy. She is getting only corticosteroid injections for an ankle. And I placed an implant in 2023 in number 3 position.
Okay.
It had pretty good stability.
Okay.
And 2 weeks after I placed the implant, the patient fractured tooth number 12.
Okay.
And I had to do extraction of number
Okay.
12. I grafted number 12, but
Uh,
she started eating on the right side.
Okay.
So the implant failed.
Okay.
Yeah.
So we have a post-implant failure on 3, and then we have a recent extraction on 12. Is that correct?
Yes.
Okay.
Recently, it's more than 6 months. It's
Oh,
close to a
more.
year, I think.
Oh, close to a year. Okay. So let's take a look at number 3 and see what we have, Doc.
So for number 3, Dr. Resnick, the native bone or the vertical height of native bone is 4 millimeters, Doc.
Okay.
And we've got the the sinus septum as well over here being prominent, Dr. Resnick.
It's not the sinus septum. It is a xenograft. So when after the implant failed, I cleaned the site and I placed a membrane and xenograft and allograft on top of it. And probably there was
A perforation.
perforation in the sinus membrane, and what you see there, it's the xenograft. I'm almost sure about that.
Okay. So, Doc, do you remember we talk about xenografts? A lot of times they don't turn over in the bone and they look very radiopaque like that.
Yeah.
So that probably is not vital bone. But anyway, you don't have enough. You're under 5
Yeah.
millimeters. So you
Absolutely.
actually need a SA4 in this case. So the problem is you remember SA4s in between natural teeth are very difficult. So if you remember in the lab, we had you use the reamer that obliterates the lateral wall. This would be a very easy case just using the reamer. So what you would do is basically just make a window by removing the bone over top of that. You would probably have to remove that xenograft because you're going to have to get back to the medial wall to build that up. Okay. So for the doctors on the call, you need at least 5 millimeters of bone to place the implant at the same time as the graft. In some areas, there is 3, maybe 4 millimeters of bone. Under 5, there isn't enough primary stability. Secondly, with that being xenograft, that won't turn over. So that would be even more of a danger or more increased morbidity. So, Doc, I would do phase 1, SA4, clean that out. Also clean some of that xenograft out, put allograft in, let it heal, and then go back in and place the implant at a delayed stage. Okay. Does that make sense?
Yes, yes, yes.
Okay. Now let's look at number 12, which you said you just grafted within the last year. Is that correct?
Yep.
Okay. That one looks good, Doc. Okay. There's a small little marrow space there. That's not a big deal. You'll drill right through it. Again, number 12, great case. Tons of bone. Doc, this is how many?
What about the distance between 11 and 13?
Yes.
Do I
So
have enough room?
what type of implant do you place, Doc?
Han, but I
Okay.
do have also Nobel if necessary.
No. You want Han in this. So you want a tapered implant. And Hussein, did you place the implant in this case?
Yes, sir. I did add an implant at the site of number 12, Dr. Resnick, at 3.5 by 11.5, sir. And the medial distal space over here to the axial image, Dr. Resnick, is exactly, sir. Here we go. 2.0
2
millimeters to the, yes, sir, to the adjacent implant, 1.2 to the lamina dura of tooth number 11. Sir.
Okay. Let me look at the length of this cross section of this.
Here you go, sir.
Okay. And scroll back and forth. There's a dilaceration on that cuspid. That's what can we look at an axial image?
Is this better, Dr. Resnick?
Okay. Yeah. So, Doc, see where there's a dilaceration on that cuspid?
I do see it.
Okay. So, Hussein, let's go make that a 10 millimeter implant.
Yes, sir.
Okay. That just you'll be far enough away from that. The only thing I would do, Hussein, on this is your 1.2 on one side, 2 on the other. Let's make that equidistant. So let's make it right in the center. And if you could tilt the tip or the apex of that implant just away from that cuspid root. The reason is we don't know if there's any vessels that are coming in close to that. So I'd rather have it a little bit closer to the implant, the apex, than a natural root. Does that make sense, Doc?
Yes.
Okay, so let him play with that. He doesn't have time now, but he'll play around with that and get it to the ideal position. Okay.
Okay.
And then on the other side, before you do that case, make sure you get in contact with me and I'll walk you through that sinus case. Okay.
Okay. Okay. Thank you a
Okay.
lot.
Take care, Doc. Okay.
Thank you.
Okay. Okay,
Thank you, sir.
Hussein.
Next case for Dr. Patel, Dr. Resnick. So, Dr.
Okay.
Patel, would you mind please unmuting yourself and presenting your case with Dr. Resnick?
Sure. So this is a 62-year-old male with a history of hypertension, hyperlipidemia, and type 2 diabetes. He's on metformin, and his A1C is 6.8. He had a severe perio in the maxillary arch. He was edentulated almost about a year ago, and at that time, there was no plan for implants according to patient. So it was minimally grafted, closed, and had a complete denture.
Okay.
And now he's unhappy, and he liked to eat, solid food.
Okay. Okay, so let's take a 3D image of this. Let's look at the upper arch first.
Here we go,
Okay.
sir.
So Hussein's going to give us a through. Okay. So as you can see, the patient's had significant atrophy, a lot of undercuts. Okay. Now, Doc, did you talk to the patient about the type of prosthesis?
Yes. So we had, preliminary conversation with him, and we were talking about RP5 and RP4 primarily in his case.
Okay. So let me stop you there. So right off the bat, this is a very atrophic maxilla. First of all, Hussein, did you get implants in this case?
Yes, sir. I was able to add like 4 implants for an RP5 restoration for the maxillary arch, Dr. Resnick. I'm going to go ahead and
Okay.
switch them on, sir. And here's the positions of the panoramic image, sir.
Okay. So 3 3.5s and then a 4 3. Okay. Can you give me cross sections so I can see those?
Right away, sir. So that's going to be implant number 5, Dr. Resnick. I'm using a 3.5 by 8 over here, sir. For
Okay.
that first implant. Then we've got number 7, a 3.5 by 10 millimeter long implant. Next, sir,
Yeah.
is implant number 10, 3.5 by 11.5 millimeter long implant over here, sir.
Okay.
And last will be number 12, a 4.3 by 10, sir.
Okay. So let's go back to the maxilla, the 3D. So Doc, a couple things. First of all, I would highly recommend you talk the patient to an RP5 on this, that it has to be a full denture. The reason is that this maxilla has a very poor bone anatomy, and you're going to need soft tissue support on this. If you try to do an RP4, you're going to have to do extensive bone grafting, not only sinuses, but you're going to have to do ridge augmentation. So I think the probably the easiest thing would be RP5, but it has to be a palatal prosthesis. Okay.
Sure.
Okay. And where he put those implants are ideal. The problem is you don't have much room for air. So I would highly recommend you do this guided.
Sure.
Okay. Maybe you could do it pilot, universal, or fully guided, any of them. But I would definitely do these guided because you don't have, there isn't much vertical or horizontal air that you can have in this case. So right where he has them is pretty good. So I think
Okay.
that's, I like the treatment plan. So 4 implants, your AP spread is pretty good, Doc. And you're just
Sure.
going to do locators, right?
Yes, locators. So regular locators should take care of these angulations, in your
Yes,
opinion?
yes,
Okay.
yes, yes. And he
Okay.
can play around with those a little bit, probably to even get them a little closer, I think. So
Sure.
when he has time, he can do that. Okay, let's look at
Okay.
the lower arch because you said the lower, right? Also,
Yes,
Right
he's
away, sir.
class 3 malocclusion, and he
okay,
currently has dentition, but I think we were thinking he may be able to get the fixed prosthesis if he's maintaining his A1C within limits.
okay. So let's take a peek here. Uh, and he's not happy with his lower prosthesis. Is that correct?
He has natural teeth as of now.
Oh,
So
I thought
he
he had
was,
some missing. Okay. So he has
yeah.
all natural teeth. Okay. No
Um,
partial.
there
No.
may be some missing. Yeah, probably.
Okay. Okay. So let's see what this looks like. And then you said possibly a fixed.
Yes.
Okay.
Here we go, Dr. Resnik.
And what?
So
Okay. So he's missing teeth on one side. Okay. I got it. So all these teeth have to be extracted, Doc?
Yes.
Okay. So let's look at a cross section from one side to the other.
here you go, Dr. Resnik. So I'm starting on the
Okay.
left quadrant, sir, and I'm going to start scrolling.
So I want everyone to look at the number 1, the angulation, number 2, the bone quality, and then number 3, the amount of available bone. Okay. Wow, he is a skeletal class 3, Doc.
Yep.
He's pretty significant. Look at that. Look at the maxilla compared to the mandible here.
Yeah.
Which you can fix in a lot of cases. Keep going, keep going. Okay. So let's go back to the 3D. So, Doc, if you want a fixed prosthesis, first of all, does the patient want a fixed prosthesis, or do you think the patient wants it?
I think that's the best we can offer.
Okay.
Again, I think his concern would be the cost, and then it would go down to
Okay.
the
So
removal.
let me give you some advice. Again,
Sure.
give the patient all the options.
Sure.
You know, from a complete denture, no treatment, complete denture, RP5, RP4, FP3.
Sure.
My recommendation on this, Doc, would be to do a RP5.
Okay.
ACE implants. Number 1, it financially that will be a lot easier on them. Also,
Sure.
I'm more worried if you do a fixed prosthesis on the lower, you're going to
Sure.
beat the heck out of that maxilla, and you're going to end up having problems. So you could do 2 over dentures, RP5. Patient would probably be very, very happy. In
Sure.
ACE position, you'd have a great AP spread, and you could do this immediate. So you could extract those teeth, Doc, do an osteoplasty, and place the implant at the same time.
Sounds good. Yeah.
Okay.
Perfect.
So
Now,
we'll. Oh, go
uh-huh.
ahead. Go.
The amount of osteoplasty,
Yes.
regardless of this case, what's the best way to, let's say
So
in this case, if I had to
what
do,
we would do, see where that undercut is? You're going to
yes,
go right to the lower undercut because remember with an RP5, you're going to want more osteoplasty than with an FP3 because a
sure,
removable needs more room. So you're going to go right to there. So this would be a
Okay.
very easy case, Doc, to take
Sure.
out the teeth, have them make you a reduction guide. You just push the bone down or level the bone out, and then exactly the lab that you did at S2 or this past weekend is
Yes.
the protocol. So it would be very, very easy and simple. And you could even do that with a stackable guide with the reduction guide. So they'll work that up, and then just have me take a look at it, Doc, and I'll walk you
Sure.
through it. Okay.
Appreciate that. Thank you, Dr.
Okay.
Resnik.
Okay. Take care.
Bye.
Okay. We gonna make it, Hussein?
Yes, sir, we are. Next, the
Okay.
case is for Dr. Esther Gebermichael. Doc, would you mind please unmuting yourself and presenting your case to Dr. Resnik?
Hello,
Hi,
can
Doc.
you hear
How
me?
are you? Yes.
I'm doing well. Thank you. Thank you. So
Good.
I
Good. What do you have for us?
a 76-year-old female, sorry.
Okay.
History of hypertension, diabetes, stomach ulcer, kidney disease. She says emphysema, but then she told me not so much. She has taken metformin, simvastatin, Ozempic, amlodipine, and Anora.
Okay.
Her A1C was a 6.4, I believe she said.
Okay.
We extracted teeth number 7, 9, and 10, and I did a socket preservation April of 2024.
Okay. And
Okay,
it
yeah,
looks
that's
like
just a wax up.
okay, so he did a wax up. So let's
Yeah.
see what you have. So, Doc, on the medical history, the only thing is be careful with emphysema patients. If they say they're not, they are on a inhaler, so they definitely have some type of pulmonary issue. So just make sure they're not smoking,
Okay.
because most emphysema patients are smokers. Their A1C is fine as long as it's maintained at that level. So, okay. As for the implants, so you're missing 4 teeth.
Yeah.
7, 8, 9, and 10. So just so everyone knows, you can almost never get 4 implants in. Usually in these cases, we look to do 3 implants, because what happens when you lose the teeth, you lose a little bit of the length of the arch. And because of that, you'll never be able to get 4 implants in. So in most cases, we put 3 implants in, 2 in the lateral and 1 in the central position. With that being said, Hussein, did you do any implants on this one?
Yes, sir. I did add 3 implants at the size of number 7, 8, and 10, Dr. Resnik. I'm using
Okay.
non-implants. I'm going to start presenting the cross-section images right away for you, sir. So that's the
Oh,
first implant,
perfect.
Dr.
Okay,
Resnik.
that one looks good. So that's a
3,
3-0. Okay, that's
yes,
good.
sir. 3 by
Okay.
13, 1.5 to the adjacent to 3 millimeters in between 7 and 8. That's 8, Dr. Resnik. A 3.5 by 11.5, sir.
Okay.
Clear away from the nasopalatina canal, 3 millimeters in between this one and the adjacent fixture number 7. And then last, sir, is implant number 10, a 3.5 by 11.5. And we're clear away from the lanyard of the adjacent tooth and good bone coverage, sir.
Perfect. Can you show me those coming out with respect to where the teeth are?
Yes, sir.
Yeah.
Oh, perfect. Wow, Doc, this is going to be a nice case. Very nice case.
Yeah.
Okay.
Yeah.
So, you grafted this how long ago?
Last year, April of 2024.
Okay. So, you're grafted real well, so it looks nice. The implants, I like the 3.0 and 7 because, again, laterals are 6 millimeters mesial distal. So a 3.0 is perfect there. You're not that close to number 8. Where he has number 8 is perfect. And number 10, a 3.5 is ideal. So, Doc, 3 implants, I think that's a home run. And right where he has them,
Yeah.
it's perfect. So I would do, were you going to do this guided?
Yeah, I was going to do it guided. I had 2 questions. One was the
Yes.
restorability space. Had he buried the implants? So I was thinking they probably needed to be buried.
Well, I
3 to
don't
4
think,
millimeter.
yeah. So, Hussein, can you give us a facial view? Okay. And then can you make the bone translucent?
Right away, sir.
Okay. And then take the teeth away, if you could.
Here you go, Dr. Resnick.
Okay. So, Doc, if you look at where the implant next should be, 3 millimeters below the free gingival margin, we don't see the tissue here, but if we go by the CEJ, I think you're right there. On number 10, yeah, I think you're right there. He can play around with that a little bit just to make sure. Are you at 4? 3.8? You can bring that one up. So the closer he gets to 3 millimeters, the more FP1 he will be. Okay.
Okay.
So is that what you were worried about? You were worried that they were
Yeah.
going to be too long?
No, just for her opposing dentition, just she didn't have much clearance, occlusal clearance.
Okay. So
Yeah.
okay, Hussein, do you have the okay.
Yeah, unfortunately, I don't have the intraoral scan, sir, but I switched on the volume render just to give us a better idea of the antagonist storage.
Would it be better if she gives you an intraoral scan on this? Or impression?
Absolutely, sir.
I sent it already. I had submitted it.
Oh,
Perfect.
you did? Okay.
Yes.
So here, Doc, here's what we'll do. Because I do see attrition on those lower teeth. We should look at that. Let's why don't you work that up, Hussein, with the intraoral scan, and let's see how much space we actually have.
You got it, sir.
Okay.
Definitely.
But I can tell you, Doc, that you will, just from where those implants are, you're going to be fine. You will have enough space. So
Okay.
yeah, I would rather not have to sink the implants deeper, because then the teeth are going to be longer. And we also don't want that bone remodeling on the mesial of the canines.
Yeah. Okay. Last question is, do you think
Yes.
I could do this screw retained?
Yes, definitely. Where he has those implants, they'll be screw retained. Yes.
Yeah.
Because it's right in the cingulum
Okay.
area.
I guess we'll get back then once we
Yeah, so
once we review
let's
the
get the
intraoral
intraoral scan, and that will give us the final position, but I think it's going to be very close to where he has it.
Okay. Okay.
Okay, and I'll look at that before that's made, the template. Okay.
Okay. Gotcha. Thank you.
Okay, Doc. Have a good night.
You too.
Okay.
Last one for today, Dr.
Last
Resnick.
one. People, we're gonna make it. Okay, let's do it.
So, Dr. Contemporary, would you mind please unmuting yourself, Doc, and presenting your case to Dr. Resnick?
Sure. Hi, Dr. Resnik.
Hi, Doc. How are you?
Good. How are you?
Good. So what do we have here, Doc?
I have my patient is a 43-year-old male.
Okay.
Medical history, he has hypertension and his current medications are amlodipine, metoprolol, and he also takes Adderall.
Okay.
He's missing a tooth number 30.
Okay.
Extracted, he's not sure when, but it's definitely been a few years. Never had a replacement in that area. So he's looking to get an implant in that area. So I just want to see how this would look.
Okay. So let's look. So when we see a space like that, so you see the bicuspid is a little bit buccally inclined. The second molar is a little bit tilted. Let's go ahead and let's look at it in an axial view and see how much, because that's one big tooth. If you would only do one implant, Doc, that would be very large. So always look in the axial view and go about the CEJ, which is about there. Okay. Oh, you already measured. See, he's
Yes,
already
sir.
thinking what I'm saying. Okay. So it's 16.7. So, Doc, that's really way too much space for one implant.
One implant. Okay.
Yeah. So usually what we do is 2 bicuspids in this type of situation. And Hussein, it looked like you already planned that out. So what did you plan out?
Yes, sir. I had in mind 2 implants. I'm using a 3.5 and a 4.3 implant. And here we go, Dr. Resnick. So the anterior one is a 3.5 by 11.5 millimeter long implant, sir. We've got decent bone coverage all around. Then we've got the most distal one, which is a 4.3 by 11.5, perfectly clear away from the mandibular canal. And I'm maintaining 3 millimeters in between those 2 fixtures. And adequate 1.5 millimeters away from the adjacent laminate uterus, sir.
Okay. The 4.3, could you make that a 10?
Yes, sir.
Okay. We don't need it 11 and a half. And just do one click apically for me.
Here we go, sir.
Okay. The reason is, I think if we take it down, maybe one more click down. There's just going to be a little bit more bone on the lingual there. Okay. Good. That's good. So, Doc, let's look at it on a 3D image on the from a sagittal view or a side view. Okay. So, Doc, see how that second molar has tilted a little bit?
Yeah.
So, is there a crown on that tooth?
No, it's a no crown.
Okay. So you'll just have to do a little bit of enamelplasty on both, just so
Okay.
you get a good guide planes on those. And he will play around with the final positioning, but I think you'll be able to get 2 implants in there. No
Okay.
problem at all. You have tons of bone. It'll be
Okay.
a straightforward case. Definitely.
And the enameloplasty would be at the restorative stage after 4 months, right?
Exactly. But when you give the patient the treatment plan, make
Mhm.
sure you add that on that you're going to do the enameloplasty.
Okay.
So you don't want them thinking that you're adjusting their teeth to fit because of your crowns were too big or whatever. So do it at the very beginning, and then
Okay.
there's no question whatsoever. Okay.
Okay. Wonderful. Thank you.
Okay. Good. Good. Nice case. Okay. Is that it, Hussein?
Yes, sir. That's it.
Okay, we made it by 8:30. So, hey, I would like to thank everyone. Thank you, Hussein. Thank you,
Pleasure,
Dr.
sir.
Robinette. We will see everyone back in a couple weeks, and we appreciate it. And let's keep it going. Take care. Have a good night.
Thanks, sir.
Thank you.
Okay.